Okay. Well, I want to welcome everyone to our Patient Safety Week webinar. My name is Charlotte Glass. I work with Envision America. And if you're not already familiar with our company, we make accessible prescription labels for the blind and visually impaired. And we're branching out into dual language and translation and however else we can meet the needs. So this health and well-being webinar series was born out of a desire to address a lot of the questions and concerns and challenges that our consumers tell us about when we're speaking with them. So we follow up with them every 6 months, and so we hear a lot of their stories. And so this is our third webinar that we've had, and I'm so glad to have Ariana Longley, Kate Ballard, and Kristen Beiers-Jones to join us today to share a little bit about patient safety and what they're doing to help promote that in our healthcare systems. I also want to acknowledge the wide range of participants that we have today. I know we have some of our own customers. I know we have advocates for the blind and for those who are English language proficient, or limited English proficiency, sorry. We have state agency workers, we have people in independent living centers, family friends. I know there's some health care workers out there. So we just have so many people that are joining us from a broad, wide range of backgrounds. I just want to acknowledge all of you. Thank you for coming. And I think it's going to just add to our conversation. And when we open it up for questions and answers, I think it's going to be an interesting discussion. So today we're going to start out with Ariana Longley. She's with the Patient Safety Movement, and they work to just increase patient safety in usually in the hospital setting, but I know you're going to talk a little bit about other things too. So I'll just let you give us a little bit of your background and just your presentation.
Great, thanks Charlotte and Envision America for having me today. I'm happy Patient Safety Awareness Week, and let me just set up here and make sure you guys can see everything okay. Can someone give me a thumbs up that they can see the slides okay?
Yeah, looks great.
Okay, awesome. So as Charlotte mentioned, I'm the Chief Operating Officer here at the Patient Safety Movement Foundation. I do have a Master of Public Health degree, so I come from the public health kind of world. I got my degree globally, so I am very interested in global patient safety awareness, and I've been with the Patient Safety Movement Foundation for just about 6 years. So what we're presenting today, and we're really thrilled to be in front of you all. We used to do this presentation in person, but we've actually found that by doing it virtually, we can reach more people, and obviously international people in this case. So I will take us through just a really short agenda for my presentation. We'll talk about who we are, who is the Patient Safety Movement Foundation if you've never heard of us. We'll talk about your safety in the hospital. I will share some free resources, hone in on a few COVID-19 resources, and then hopefully we'll have plenty of time for a Q&A. So with that said, Charlotte mentioned a little bit about us as the Patient Safety Movement Foundation. We have this very bold vision to achieve zero preventable patient harm and death in healthcare by 2030. So if you're just getting introduced to us as an organization, we have very bold and audacious goals, but we have these set because we believe that zero preventable patient harm and death is achievable over time when we get the public involved and the right stakeholders involved. And we have to shoot for zero because one is too many. We can't just focus on 99% of people. Each one of these people that are affected by medical harm are, your friends, your family, and could be each and every one of us today. So our mission is to urgently unify people and collectively improve patient safety across the globe. We currently work with over 54 countries. So it was great to see some people from UK and Panama as I saw them joining. We really started as a US-based initiative, thinking that, we're based here, might as well improve patient safety in the US, and very quickly into our second and third year, got interest from Lithuania and Japan and Brazil, and thought, why not open it up to the world? We really have to focus on this global issue, and there's lots that we can learn from other developed countries and developing countries. So that's us on a real basic level. We work with as I mentioned, all stakeholders. So we're working more with the public. We did actually, I think this will be my next slide. So let's focus on your safety in the hospital, and I'll talk a little bit about some facts first. So first is last year in April, in the midst of lockdown, when pretty much everyone was locked down, we decided to do a public awareness poll. What I'm presenting to you here is based on US numbers. However, we're currently in the midst of repeating this survey, and we'll be also polling English-speaking countries. It's really expensive to poll and translate, so we're going to start with the English-speaking countries outside of the United States for this next year, and then hopefully be able to expand beyond that in the future. But the point of the survey was to determine, how much does the public know about patient safety, medical errors, etc. And what we saw here was that if you combine the no, I have not heard or read any reports on medical error in my state or local community, and yes, I've heard just a little, that's 91% of people who really don't know anything or just a tiny bit about medical errors. Only 9% have heard a lot. So we've got a lot of work to do during this Patient Safety Awareness Week. All of us who are panelists and all of you out there, we have to start talking about this more. And why is that? That's because medical errors are considered the third leading cause of death in the United States in a normal year. Now, I don't want to overlook the fact that COVID-19 has claimed the lives of way more people this year than medical errors. As we know, in the United States alone, over 500,000 people, close to 500,000 people have died already. So yes, COVID is the third leading cause of death this year in the United States. But remember, next year, if COVID goes away, medical errors are going to climb right back up there. And we also have to consider that COVID has led to a lot of other patient safety challenges and harm and death. And we've seen for the first time all of our health workers becoming patients. I mean, I think that's been a really overwhelming realization for all of us, is our health workers were not protected and didn't have the ability to keep themselves safe. And if that's the case, how can they keep all of us as patients in the hospital safe too? So estimates range everywhere. We don't truly know the number of medical errors in the United States that are killing people, and we don't know that globally. There are some estimates that show the study here on the bottom right that came out in 2016 out of Johns Hopkins said that number was around 250,000 people in the US. Other reports have claimed up to 440,000 on a global basis. Since I know that there are some people here globally, we think that number is around 3 million that are killed by medical errors every year. The harm is exponentially higher than that. So I just included some headlines from different news outlets across the world. Some of them are a little funky and fun, and fun in not a good way. I shouldn't say that. It's not fun. It's, baby died in dad's arm after bungling hospital medics made 5 major mistakes. Grandmother died after having liposuction. Why do so few people know? And then this one is maybe a little bit more like, shocking, and medical error ends with teen's thumb replaced with toe. So there's just all sorts of things that are happening out there that, people may not see in their own local newspaper and may just be happening in certain regions. So we need to continue to raise awareness and work with the local media to make sure that this information is shared more broadly. That one got messed up there. And then the one thing I wanted to, again, bring this back to COVID. This was a report that came out or a news article that came out in USA Today in August, and the headline says, as COVID-19 spread, the feds relaxed rules and hospitals tried to contain the outbreak, other infections may have risen. So I talked about this a tiny bit, but what we've seen is when hospitals had to start responding to this pandemic, some of their other patient safety initiatives that they were working on and doing really well, whether it was infection-based metrics or falls or whatever it might have been, they had to divert that energy from focusing on those patient safety issues and divert it to COVID. So it's likely that other patient safety concerns have really risen during this COVID-19 pandemic. And to bring it back to some of what we've seen, a lot here in the United States and in other countries, the safety of healthcare for ethnic minority patients is a huge concern. What this study from 2020 from July says is that patients from minority groups are at a higher risk of patient safety events, which are events that could have or did result in harm to the patient compared to the mainstream population. We see this a lot with Black mothers being affected more by pregnancy-related issues, and their babies are affected, but it's really a systemic problem that we have to continue to address. So I'm now going to give you just some tips, and remember, I'm not a doctor. I have a public health degree, but I'm not a clinician. I've never cared for patients directly. So I'm presenting these to you based on what I've learned working in the patient safety movement for the last 6 years. If you do leave questions and comments at the end that relate to more clinical kind of topics, I'm happy to bring that back to our team and have them answer it. But I just like to have that as a disclaimer. So the first thing to consider for your safety in the hospital is how can you prepare for your hospital stay? So one is kind of research your medical issues, search the web. I'm sure that lots of providers would say, oh gosh, Ariana, why are you telling people to search the web? We hate when people search the web because they find all these crazy things that don't actually pertain to them. But it is a good idea. If you know what you're going in for, if you know that you're going to go in for a hip surgery, do some research on hip surgeries. Make sure that you don't have any questions about what they're going to be doing to you. And if you don't know what the concern is, then, again, it can be sometimes helpful, or at least ease your mind if you do a little bit of searching on the web. It's way easier today than it was 20 years ago. The second that people don't often think about is researching your doctor. While we don't have a Yellow Pages or Yelp for doctors, there is an alternative. We aren't sponsored by this group. This is all just based on information that we've provided. I'm sure that there are other groups out there, but healthgrades.com is a tool that you can use to look up your doctor. If, let's say, you've been referred to a specialist and you have to go see a specialist and you don't know which one to select, healthgrades.com does give some ratings and information about your doctors and health workers. So it can be helpful to just see, what kind of patient ratings do they have, what kind of credentials do they have, and can be really helpful. Third is your hospital. So I think sometimes people start thinking about, oh, well, I have the best doctor, I have the best neurologist, I have the best surgeon. That's great. But remember, when you're in the hospital, there's going to be dozens of people that are likely caring for you. So it's also important to consider where you're going to be getting your treatment, where you're going to be seen. And so there are two tools. One is Medicare's website, and they have a tool called Hospital Compare. And so you can type in your zip code and really easily see what kind of ratings your local hospitals have. So that could really impact you depending on what you're going in for. And they do go into very specific detail, around, cardiology versus, orthopedic surgery and things like that. So it may help you pick the right place. One thing to consider is that some hospitals are known for having, specialty treatments. So if they're doing high volume, they're likely going to be doing better than if one surgeon at another hospital does that, surgery once a year. So consider that type of information. And then there's the Leapfrog group. They are a nonprofit, and they basically take that hospital compare data. They get it directly from CMS, and then they survey hospitals. And when those surveys come back, they're able to supplement and create a new score. So they actually will rate a hospital or grade a hospital from A to F, and you can see the data behind that and why they've been graded that way. So those are some great tools to kind of prepare for your hospital stay. Now, some other things that you could consider is, what are your possible risks and alternatives to the proposed treatments that you might be going in for? So, for example, what kind of complications might you expect? Is it just bleeding at the site of surgery, and how much bleeding is concerning? If there's just a tiny bit of blood, do you need to call, your doctor, go to the ED? Those kinds of questions are really helpful to ask. A second would be, what should I be concerned about based on me? Is it that I might be at higher risk for blood clots? I might be older and I might have to worry about delirium. What kind of concerns, you should be able to ask, what should I be concerned about? And your doctor, nurse, whoever's caring for you should be able to provide you with some answers to that. And then third is there anything else that you might do like instead of surgery? I'm just going along with the surgery example. So is it maybe there's some diet change, some physical therapy, exercise, is there anything else that you might want to do before you move into something invasive? And definitely not saying in any way, shape, or form that surgery is bad. It's much more invasive than some of these other things. So next is, what should you bring with you? So we're going to first talk about kind of your medical records. And some people might say, oh, well, I don't have my medical records with me. I don't have them printed out. That's fine. There's still components of your medical records that you may have access to. Now, you can always ask. It is your right to ask for your medical records. So you should be able to contact your doctor and ask for that. But if you don't have them and you still want to look at some options, what you should bring with you is your problem list. This isn't necessarily a physical document, although it could be, but you should be kind of saying, what is your chief complaint? Why are you in the hospital? Are you getting hip surgery? If so, that is your chief complaint. But in addition to that, you should also be able to share with your practitioners, what kind of medical problems and other treatments might affect that chief complaint. So are you going in for hip surgery, but you're also diabetic, or you're also anemic, or you have COPD, or you have certain allergies? That information is very important to complement that chief complaint, because if they don't know that you have an allergy and then they give you a medication that you have an allergy around, that could really create some complications and make your surgery not as effective and harm you. Second is your medication list. So that if you have that printed out or you have a list of it somewhere, that is great to bring. But if at all possible, if this isn't an emergent situation where you're having to get rushed off in an ambulance, the best thing would be to bring your medications. People oftentimes will throw them in a baggie, a plastic baggie or a paper baggie, and bring them along. The benefit to doing that is that sometimes if you're seeing multiple doctors, you may end up getting the same prescription or the same type of medication prescribed twice. And so oftentimes when you combine all of those into one place and look at them, when your doctor or pharmacist are able to see those, they can say, you know what, these two do the same thing. You really don't need to be taking those two. And so that's called medication reconciliation. And that can be a really helpful time to ensure that you're really taking what you ought to be. Now, this is a graphic from the World Health Organization. It was created in 2018 based on their Global Medication Without Harm campaign. And so there's 5 moments for medication safety. And so those moments are when you're starting a medication, taking a medication, adding a medication, reviewing a medication, or stopping a medication. I won't go into the details here. There are some common questions underneath here. And the reason I'm not going to go into details, there's actually a mobile app that I'll talk about that has a lot of this information in it later in my presentation, but it can be really helpful. It's the first time that the World Health Organization has come out with a consumer-based mobile app that can be helpful to people around patient safety. And then still continuing down the road of medical records, what is also helpful is what other previous surgeries or related treatments you've experienced. So what was done? How did it go? Did you experience any complications? And how did you tolerate anesthesia? Those are some good 4 categories of questions to ask. Because if you had a complication before, let's make sure that they don't repeat that same complication you might still be at risk for that complication. And lastly, if you're going to be under anesthesia and last time you had a really hard time with that anesthetic, they might be able to change the type of medication, the type of anesthesia that they would give you to have you have a better result after coming out of anesthesia. So second tip, and this is my most important slide, so if you only listen to one thing, please listen to this. Always assume that the best information about you will come from you. So you know yourself better than anyone else. So if you are able to advocate for yourself, that is preferred. However, if you can't, if you're incapacitated, if you are in an emergent situation and someone else has to help kind of communicate on your behalf, then please consider bringing an advocate. I'm going to define an advocate real quick because I think it will help you select a better advocate. It's a supporter, a believer, a sponsor, a promoter, a campaigner, backer or spokesperson. And this is, you have to make sure that you're picking an advocate who has these three qualities. They have to be someone you trust. They're going to be perhaps having your life dangling in their hands. Second is they have to be willing to take action on your behalf. So if your go-to that you're thinking of is someone who's not going to step in an uncomfortable situation and might be scared, consider whether they're the best advocate for you. And third is they have to be someone who works well with others. I'm going to smile through this, but if you have a partner or someone, a family member who has a short temper, it kind of, won't work well with others, it's really important that you have someone who can kind of speak diplomatically and speak up, but not, tick anyone off. So consider that. And, it could be a neighbor, it could be a friend that knows you really well. They've known you for 20 years, doesn't necessarily have to be a family member, but they also need to be willing to show up for you and be able to be an advocate for you. So let's see here. So free resources. So we're getting to the end of the presentation now. I do want to mention a mobile app that we've created. It's called Patient Aider. And I want to highlight to everyone who's here on the phone now that we do have this app available in English, Spanish, Arabic, and traditional Chinese. So I know that Envision America does a lot of work around translations. So it is important for you to know that I am showing just the English version, but we do have those other versions and people can easily switch back and forth. So you download one version and can kind of toggle what language you'd like to see. But this helps you prepare it separates into three categories. If you're at home preparing for a hospital stay, if you're in the hospital, or if you're at home recovering, and then we'll give you different topics that you can kind of learn more information about. Because again, most people don't know that there's these risks. They think the hospital is perfectly safe. That's why they're going there. And so they may want to consider doing some research about falls or blood clots, or if they're a pregnant mother, what about bleeding after birth? What's normal and what's not normal? So this can be a really helpful tool. I'm just including this kind of set of directions for downloading Patient Aider. Obviously, if someone's rewatching this, they can pause on it. I will not go through that right now. And then we have two different kind of types of resources on our website. These are just a number of other organizations who've created excellent resources that we love to link people to. These are more of like guidebooks or checklists, big, not checklists, packets of information that you could download and bring with you as you prepare. The second set are individual checklists. So, 10 things patients should know about safe postoperative pain management, or being admitted to the hospital for any reason. These are a set of questions that you may want to ask. And then the one I do like to point out is the one here on the bottom right. This is all the definitions of the people that you might interact with in the hospital. What's the difference between a charge nurse and a first-year resident, or an intern, or an attending? Sometimes that can get really confusing if you haven't been working in healthcare. Who are these people and what are they going to do to me, right? And then lastly, around COVID resources. So we understand that I'm telling you, look, have an advocate, but visitation is really limited still here during the pandemic. So it's not always possible for advocates to be at the bedside. So we do have some recommended resources for what to do as an advocate, and if you are hospitalized during the pandemic, what you can do. So I've left that information here. So with that said, I think we should have some time for Q&A. So I will, I guess, open it up to the Envision America team to let us know what questions there are. And please do feel free to email me if you have any questions and don't feel comfortable asking them now.
I just know there's been a couple questions about will these slides be available and so forth. We will include a link to the completed recording to everyone when this is done in the next day or two. And I also plan on preparing a printable sheet that has a lot of the websites that she's quoted. So both of those resources will be available in the future as well. So if you have a question, you can enter it into the chat or the question and answer, or you can raise your hand. Any one of those, and Richie and I will call on you.
Charla, we do have a question ready to go from Marcy Ramiro. And it is, do patients have the option of choosing what hospital to recover post-surgery. For example, the surgery is completed at hospital A because the surgeon is rated highly, and the patient recovers at hospital B because hospital A is rated poorly on HCAIs. Is it possible?
That's a great question. It is difficult to get transferred. So I think the preferred kind of scenario would be that you find someone that you'd like to get, you find some doctor and a hospital that you can kind of complete your care all in one facility. The reason that I say that is if you do have to get transferred and you end up being in an ambulance, and let's say they have to intubate you, that's a whole different problem. You do not want to be in an ambulance where they're going to have to intubate you and move you around. That's a whole, another set of risks outside of, normal hospital care. That would be like, EMS care or paramedic care. So it would be preferred that you probably try to find somewhere that is good with surgery and has a low rate of infections. And that is possible. So that should be possible for you to do. You just might have to consider it may not be the hospital that's 0.5 miles down the road. You might have to go 5 miles, but it may be better to go 5 miles and find somewhere that is going to have, your comprehensive, continuum of care that's optimized.
Thank
Great
you.
question.
Yeah, that is a great question. You don't really think about things like that.
Yeah.
There's another question here. It looks like it's pertaining to the app from Joanne Stamp. She says that there's 2 apps on your site, the Patient Aider, and the second is APSS app. Is there a difference?
There is. Great question. And I'm glad someone's already poking around on the website. So Patient Aider is our public facing app. So that's the one that I showed just here. And that's for all sorts of information about how you can stay safe in the hospital, right? The Patient Safety Solutions app, or the APPS app, is geared towards healthcare administrators and clinicians, and that gives them the tools in order for them to provide safe care. So we tell them about how, for blood clots, they can make sure that they're not going to give their patients blood clots, what they can do from a hospital perspective to reduce falls. So you certainly can download it and see what we're recommending. There isn't, any login or cost to that, but it likely won't be as helpful as Patient Aider would be. Great question.
Another great question. Okay, it doesn't look like we have any open questions right now in the Q&A.
There's a question on the line.
Yeah, do you want to let them in?
Sure. So phone number ending in 2704. You can unmute now and.
Hi. My name is Nancy, and I wear hearing aids. Your voice is loud and clear, but I didn't hear how do you spell the word after patient? Patient aider? I didn't hear the word after patient. That's one part of my question.
So it's Aider, AIDER, like you're
Aider.
Providing aid.
I thought you said Aider. Yeah, okay. And then also, this sounds terrible, but what if you don't really have a trustworthy or someone who has time to be an advocate? I had AFib surgery a couple of years ago, and I was my own advocate. Well, someone picked me up in the end because I had to get back home. But a friend picked me up, but people were working. Well, what if you don't have an advocate? Are there any organizations one can? It might be a stupid question. I hope not.
No, not a stupid question at all. I have heard that before, and it's the reality for some people. So there's 2 options. One is there may be organizations who would be able to serve as an advocate. They probably won't be able to be out with you, but there's the National Patient Advocacy Foundation, and they are oftentimes able to help kind of supplement and provide you with a little bit of support as an advocate, but they're probably not going to show up in person. Second would be if it's possible, you can hire a patient advocate. So if you can't find a friend or family member that's able to be with you, there are independent organizations that you could hire someone to serve as a patient advocate. And that could be anything from, preparing for your hospital stay, helping you recover, or could just be an advocate around billing. Like, let's say you're having a billing issue. They might be able to provide you with information about how you've been billed and how to, because about 30% of all hospital bills have some type of error in them. So there are issues that sometimes it can be hard to navigate how to solve those. So I know sometimes it's hard to find someone who can help you, and if you have the option to pay for it, that also is an option. There are lots of resources out there. I will shout out to one that's one of our partners. It's called Greater National Advocates, and their website's gnanow.org. They're a nonprofit, but they do charge for their services around patient advocacy.
Thank you.
You're welcome. All right, any other questions?
Yep, we have 2 hands raised here. Next, we're going to go to Jeff. Go ahead and unmute and ask your question. Jeff,
Oh, hi, everyone. Can you all hear me?
yes.
Yep.
Okay. I'm really happy with the medical care that I'm getting. However, I'm living away from the area that I had concerns about. But how do I deal with a doctor or hospital official who's breached HIPAA in terms of giving information to other people who I haven't authorized? I've had that happen a few times when I was living in Michigan. And I also was in a situation where I was very weak and they wanted to roll me down for a test, which they did. And they left me alone for quite a while down there. And they were lucky that I was able to hoist myself back up to the extent that I could have, but I had concern that I would have fallen off the gurney. And I was in high school at the time, and I asked questions and everything else, but even when I was conscious and fully alert and aware, they treated me like I wasn't even in the room. I don't know, because I was 17, and I don't know if that was an age concern or doctor just saying, we know better than anybody else. So like they would talk to my parents, and then I've always been afraid that if I'm in the hospital for whatever reason, and say my mom did come up because she lives out of state, I'm afraid of them talking to her and not to me, and then treating me like I'm not in the room, even if I'm fully aware. And the other thing with the incident with the gurney, where I nearly fell off. I don't know what to do as far as immediate concerns go.
Yeah. Great questions, Jeff. I'm going to try to hit all of them here briefly. Regarding the doctor that breached HIPAA, depending on the state, there's different mechanisms for reporting that information, but I would highly suggest that you do make some kind of report about it. The only way we can learn is if we get those types of reports, and perhaps you're not the only one. So if there's multiple reports that have been filed, about this doctor, it may make a difference. So I would suggest that you take a look at, what it would be like in Michigan to report. If you'd like to send me an email, I might be able to help you research that a bit. I don't know a lot about Michigan, to be honest.
I don't need to report anything now. I'm just basing it on a time where I was really sick, was in the hospital. For the most part, my experience there was pretty negative, and I still, up until I moved, I still if I go into that hospital, I can't stay there for a very long period of time.
Yeah.
Everybody there, a majority of the people there were really rude. They just set aside my concerns, and it's not like I was a child. I was almost 18 years old, and feel that I would have had a right to ask questions. And I'm just concerned about something like that happening in the future.
Yeah. No, you're absolutely right, Jeff. It's a really great point that you bring up, because there still is a lot of resistance to, practitioners involving the patient and family as much as they should. There still is a lot of people out there that, look, I'm the doctor, I went to medical school, I've been in this training for a long time, I know more than you. But there is a shift going on out there, Jeff, and we call it patient and family engagement, or person and family engagement. And there's a huge drive to make sure that in the future, you're not treated as just, you know, a product, right? Or something that they do something to. It should be that you are a person that they are engaging with, and having conversations with in a collaborative way. So it's hard to hear that you've had that experience, Jeff, but it does happen. And the one thing that you can do is, you know, proactively in a very positive way, say, you know, look, I want to be involved as a partner in my healthcare. How can I make sure that, you know, I'm heard and seen? But it is a problem, and I'm really glad that you brought that up. Yeah.
All right. And then there's just one more thing. When I was in the hospital back when I had this allergic reaction to Dilantin and Tegretol, and hopefully they change this, but who knows? My aunt works in infectious diseases, so she can interpret lab results and all this other stuff. They were able to go out to the nurse's station, grab my chart and reports, and interpret. My aunt looked through them, and I don't remember any family asking the nurse or the doctor, you know, can we take a look at this? Our family member here is a lab person with infectious diseases. They never even asked. They were just able to go in there to the nurse's station, grab the chart, and I'm concerned about that happening too.
Well, the good news and the bad news, Jeff, is most of the charts have now moved electronically. So you would have to have some kind of credential in order to open up the chart. So the likelihood of your aunt, you know, being able to just go and grab one is very unlikely these days. So that's the good news. Security is increased because they're no longer pieces of paper most of the time, unless it's an emergency. So I think that's one thing that's being done to solve that. There are some movements. There's called the open note movement, where patients and family members would have access to certain parts of their medical records, which can be really helpful because you could catch, you know, if there's an error and help address that kind of before it becomes, you know, a severe harm or death. But yeah, digital helps solve that in some ways.
Okay.
So
Thanks,
Because
Jeff, for your
they were pounding HIPAA through us backwards and forwards when I was volunteering at a children's hospital about 10 years ago. And they never made any indication as to what to do with reporting anything.
Yeah, it's in the fine print.
Yeah.
Thank you for your questions. We're going to move on to
Sure.
Joseph McKeezy. And oops, wrong person here. All right, so go ahead and unmute, Joseph, and you can ask your question.
Can you hear me very well? This mic isn't
Yes.
excellent.
Yeah, we can hear you.
Sorry, guys, I'm late. I appreciate it. I've had a hell of a time like Jeff has. I don't care about HIPAA. HIPAA, I think, is overdone. I've talked to, let me go through a couple things. I was treated very unfairly. I had an endoscopy. I wanted to record the operation because I have read Dr. Schlachter's book. He's a lawyer. He talks about the mistakes and the horrible things that happen. And the nurses just want to get the patient through. I mean, there are some nurses that are sweet. And I think this COVID thing is another issue. They've overdone it, but that's another issue. They wouldn't let me tape record my endoscopy. They let me record when I had a surgery. It was a small surgery. It was not surgery. It was another endoscopy, and they had to clear out my esophagus. I had Barrett's. But then I had an anesthesiologist the second time I was going to have links put in. He was very nasty, and I made him leave, and they wouldn't get me another one. The hospital advocate did nothing. And so you girls could know, you young ladies could know, I don't have the money to pay for advocacy. The whole hospital thing, nurses were sweet, some of them, but these people, you don't need to know this, or don't worry about it, or you can't record it. I said, if something happens, it'll be there to help both people. Last time, you know, the doctor and the patient, the doctor didn't mind, but the nurse did. All she had to do, the first time I recorded it was okay. They didn't mind. Now the hospital's policy, I don't care about your damn policy. You know, it's a patient's right. And is there anything you guys can do? And about this HIPAA, can we explain this? Because everybody misinterprets it. HIPAA means, if, from what I was told, if you're visiting a friend, they can give you basic information unless he or she verbally, like my doctor, Dr. Noble, said, most people don't understand the HIPAA and all this. And I think it just, years ago, it was so different. You'd walk in, you'd visit with your friend, you'd stay if you wanted to. And I know in the bombing, ladies, there were family members there. They wouldn't leave one of the patients, and they just changed shifts. And that person got better. But I don't have a good family. So I'm glad you pronounced my name right.
Thanks, Joseph, for your question. We'll let Ariana address that then.
Maybe you can. Maybe you could call me sometime. We can talk. Do you have my number?
Sure. I don't have your phone number, but you can send me an email, Joseph, and I'd be happy to connect with you.
Can you send me an email? My email, jdmckeesey at gmail.com, jdmachise@gmail.com.
Sure.
I don't have your
email. And I'll be brief because I'll email you, Joseph. But one of the things that I was just going to address is there is a movement in some states right now. There's some good movement in Wisconsin about creating an OR black box. So just like there's a black box in airplanes, why isn't there a black box in the OR and when you're being cared for, so that if there's something that goes wrong, you have that kind of video evidence of exactly what happened. So that's a short answer to what you asked about, but there is some movement there. But the major issue, Joseph, is transparency. A lot of the doctors and nurses and other healthcare providers are afraid of that kind of thing because we have such a punitive system. There is not a culture where they feel like they can be open and honest if something happens. And so for that reason, they just say, no, we don't want any legality. We don't want any liability. They just hide behind the lawyers because of that really poor culture. So what all of you can do if you are a patient or a future patient is you can help, advocate for change in healthcare. You can bring this up to your legislators, bring this up to your doctors and healthcare providers and hospitals when something isn't going well, so that we can hopefully improve the system together. So thanks for your questions. I really appreciate it.
We just have a few more minutes with Ariana before we move on to our next speakers. So Richie, were there any other questions or anything that we needed to address?
Joanne did make a comment, and I'll read it out loud for everybody because I think it's a pretty good one. It says, if you are an individual with a disability, you may be eligible for free services, including advocacy from an independent living center. They have staff who can act as a medical advocate for people who have a disability. However, each independent living center is different. If they can't provide someone to provide advocacy, they can help individuals by providing information and referral services to find a resource for a medical advocate.
Okay, that's great.
That's awesome. I'll add that to my presentation. So thank you so much.
So if anyone has any other questions for Ariana, we will share her email address in our follow-ups, and you can contact her or her organization, the Patient Safety Movement. And we encourage you to check out their app and their website, because their website has tons of information as well. So thank you so much for joining us today.
Thank you so much. It's been a pleasure.
So now we're going to introduce two wonderful women who are working their hearts out to advocate for their patients. We have Kristen Beiers-Jones and Kate Ballard. Sorry, Kate. So they are working with, well, you know what, I'm just going to let you explain, what you've been doing and where you're going and all the good stuff. All right.
Thank you so much. My name is Kristen Beiers-Jones. I use she, her pronouns, and I'm an assistant professor of nursing at Oregon Health Sciences University in Portland, Oregon. I really want to thank Envision America for inviting us today. It was really thrilling to find out that we had fellow advocates who believe in equitable access to safe medication practices. So thank you so much.
My name is Kate Ballard, and I'm a nurse at OHSU Dornbecker Children's Hospital, and I'm also a former student of Kristen's. Thank you so much for having us today. We both advocated for SB 698, a law that requires Oregon pharmacies to translate prescription labels. This legislation was important because, to put it simply, the only difference between a medicine and a poison is understanding how to use it. The story of SB 698's passage is special because it was primarily written and advocated for by nursing students, a professor, and our patients.
Next slide. Okay. So this is a photograph of a home visit with my nursing students and a family. I teach population health or community health nursing through a unique program at OHSU School of Nursing called ICAN. My practice is in the community with a focus on refugees and immigrants with complex medical and social needs. Students visit their referred patients in the patient's homes each week. And this photo shows students on a visit reviewing medications with a patient who does not speak English and cannot read the many pill bottles that belong to her and her children. Next slide. So, as I said, reviewing medications is what the students do when they visit these homes, and they were finding a high rate of medication errors among their patients. This quote from one of our patients I think really is poignant and says it all. I have so many medicines, they just give them to me. I can't read what they're for. Medicine is supposed to heal you, but it can also kill you when you don't know how to take it. So this woman actually became one of our fellow advocates when we testified in front of our legislature. Another, because I really believe that stories are what move people, I just want to share one other story. We had a family from the Middle East, and the mom spoke many languages, was highly educated. She just didn't speak English. She had several children who had asthma. And when the students went on this visit and reviewed all the medications, they realized that she had inadvertently mixed up the inhalers and was giving the wrong inhalers to her children. And that led to a hospitalization for life-threatening asthma attacks for one of the children. So the students started working with their patients to identify this systemic issue. And as they listened to their patients, they began to see an injustice in our healthcare system. Next slide. So, being students, the first thing that they did was research. They went into the literature, they looked at the data. These are some of the things that they found. 220,000 Oregonians have LEP or limited English proficiency, and we will be using that term throughout this presentation. 25 million people in the United States have limited English proficiency, and there are multiple studies. One study shows that the rate of medication error is 2.5 times greater for those with limited English proficiency. The average cost of hospitalization for preventable medication errors, $15,000. So you can see that these medication errors, cost all of us because of these high costs of hospitalization through these errors. We also found a study from the New York Academy of Medicine where they found that with translated labels, that patients were significantly more likely to take the medication correctly. The other thing that students did is they looked at the pharmacist's code of ethics, and the code of ethics mentions that a pharmacist needs to communicate with patients in terms that are understandable and to respect personal and cultural differences among patients. We include this map on this slide because again, this was student research. In fact, Kate was a student who did this. We knew that we would hear that some of our legislators were concerned that maybe they didn't have too many people in their community who didn't read English. And so Kate did a wonderful job of looking at the data throughout our whole state, and this map represents that. We can go to the next slide. So the other thing the students did is look at what is currently the law. And the Civil Rights Act and the Affordable Care Act, They both make it clear that pharmacies cannot discriminate based on language, but it becomes less clear when you dive into that and try and figure out, what do they mean by meaningful access? What does that mean? We found that, there were pharmacies that would call an interpreter on the phone. I have to tell you that there were many pharmacies that did not, but they did, a lot of them did provide oral interpretation through the phone. But does it also mean written translation? What does meaningful access really mean? And so that's what really led us to realize we need to make this more clear. We need to have a law in Oregon that makes it clear that, that oral interpretation is not enough, that people need to be able to read their pill bottles. People who can read their pill bottles in English, because we've decided long ago that that was safe practice. It should also be safe practice for people who do not read English. Next slide. So the students also discovered that there are laws in New York and California mandating that pharmacies provide translated prescription labels. The advocates in New York were particularly helpful to us as we went down this path. And we really hope to pay it forward and help other folks pass similar laws in all of your communities. This photograph is from one of our local pharmacies. This is a pharmacy that is a small, independently owned pharmacy. And she figured out that in order to meet the needs of the community that she served, she did provide translated labels. So she was a real inspiration to us. Next slide.
So after extensive research and coordination with patients, medical professionals, and others, students determined that legislative action was best and what the basics of the bill should be. They met with and selected chief sponsors in the House and Senate. They also obtained endorsements from 24 community organizations. With the assistance of a newly formed core team, students helped write the legislative concept. It outlined the components of the bill based on clinical experiences, patient statements, and professional consultations. For example, we knew that it was important for the bill to require translations be on the bottle rather than in supplemental packets. In January 2019, SB 698 was introduced to the Oregon legislature. We compiled data, created one-pagers, and made maps for informational purposes. We lobbied dozens of legislators at the Oregon Capitol and gathered strong bipartisan support. Our first round of testimony was in the Senate Committee on Healthcare. Students shared cost analyses, stories of medication errors, and powerful statements from our patients. Dr. Brian Park, a member of our core team, shared that as a first-generation Korean American citizen, his family experienced a language-related medication error. Decades later, he had patients with LEP facing the same life-threatening situations. He pointed out that in the 30 years spanning his family's and his patients' medication errors, we've developed a wide array of medical innovations: immune-changing drugs, electronic medical records, tiny robotic surgeries. And yet we still have not helped patients with LEP simply read their medication labels. And to clarify, I wasn't sure if we said it earlier, LEP stands for Limited English Proficiency. So SB 698 ended up passing through the committee unanimously and through the Senate floor with bipartisan support. During this process, there were challenges and questions from others. Primarily, they were about cost, liability, bottle and label size, and translation safety. I won't delve into them yet, but if you have questions about these topics at the end, I'm happy to address them. In the House, we negotiated amendments with pharmacy lobbyists and legislators, primarily addressing liability and covered pharmacies in particular. In the House, we negotiated, whoops, I skipped too early. So SB 698 ended up passing through the House committee and through the House floor with bipartisan support. And then in June 2019, Governor Brown signed SB 698 into law. This law went into effect on January 1st, 2021. It impacts about 200,000 Oregonians with LEP across the state. It requires that both the English and the translated instructional phrase be on the bottle, not in supplemental documents. And translations must be available in at least these 14 languages. This story demonstrates the expansive skill and capability of nurses to advocate. For nurses, in addition to our medical education and evidence-based practice, we spend long amounts of time with our patients. This allows us to listen to their experiences and identify safety issues and healthcare disparities, making nurses uniquely positioned to advocate for systemic change. My fellow students and I were not professional lobbyists, but we were still successful in changing state law to benefit patients. I learned that you shouldn't feel unqualified just because you haven't had that experience before. However, our success was not without great preparation. For example, we researched how to give an elevator pitch. We looked up every legislator before we spoke with them and shifted our pitch to address their district and their priorities. We listened to and formed therapeutic trusting relationships with our patients. We backed up our recommendations with evidence and so on. So what's next for prescription translation? Right now, we're working on the implementation rollout here in Oregon, and we're also trying to share our resources with other states to encourage passage of similar legislation across the country. Nevada just introduced a similar bill, AB 177, to their legislature. Today, we encourage our listeners who come from across the country to consider passage of similar legislation in their own states. Thank you for your time, and we're happy to answer any questions you all may have.
Thank you so much. And I know there are some people on the call that are working on audible prescription label legislation. You guys were doing your bill, same time Oregon's American Council for the Blind was working on that. So, you know, if you have questions about working on legislation, I think Kate and Kristen would be a great resource, you know, to ask them questions as well about their experience. So we're going to go ahead and open it up for questions. And I see Kathy already is out there. So Kathy, if you want to go ahead with your question, you'll have to unmute first.
Thanks, Charla. And thanks for the presentation. That was really illuminating. My name is Kathy Sola-Acevedo. I'm with the Florida Braille and Talking Books Library, which is part of the National Library Service for the Blind and the Print Disabled. So as you can imagine, accessibility is huge on my list of priorities and interests. And my question is basically regarding how you pick the languages, the 14 languages that would be required for translation. Oregon has got a lot of diverse populations. I'm just curious how you did that, because Florida has a lot of diverse populations too. Thanks.
You know, it was an interesting process, and it really was a great lesson in why it matters to really understand the population you're working with. Our initial thought was to just look at census data. Let's just look at, what are the most common languages in Oregon, and that's it. But because we work with refugees, we knew that some of the most vulnerable people were people who had newly arrived to our country, people who didn't have a lot of English speakers in their community. We also knew that poverty really plays a role in accessing English. And so the students looked at 3 data sets. They looked at certainly the census data. They looked at refugee data in Oregon, and then they also looked at the Medicaid data, what languages were, and the Department of Human Services, what were they needing to translate. So they took those 3 data sets, they ranked them depending on where they appeared on that data set, and that's where they come up with the 14 languages. We also made it, we know the Board of Pharmacy doesn't have an expertise in language, right? So
Thank you. I think that's interesting because, as having also been a census worker in the 2010 census and in traditionally hard to count areas, I do know how hard it is to get people to come forward and be counted. And it's so, I think it's good that you didn't depend on just one source. That's a really good answer, and thank you very much.
You're welcome.
Thanks, Kathy. All right. We have Anne Ryan made a comment, amazing work and presentations. So thank you, she said. And Kristen, I just want to acknowledge you put in the chat. So for people who are on the phone, earlier, Kristen had shared a book by Sana Goldberg entitled How to Be a Patient. So that was another resource that she was putting out there. Just want to make sure that the things in the chat are accessible to everyone. Are there any other questions out there? Okay. Gallegos is asking, do you have any Utah connections yet? This would be so helpful for our refugees.
Not that I know of. Kristen, do you know of anybody in Utah that we've been in contact with? I think it would be great if you are interested in championing something like this, or you know a group who would be. We included our email, rxtranslationlaw@gmail.com. If you want to send us an email, we would be happy to work with you on that and connect you with the resources we used here in Oregon. Thank you.
All right, that's great. I didn't know you guys had a special email, so now I'll be sharing that with everyone.
It's brand new.
Okay. Any other questions out there? Anybody who have an experience that they want to share in this regard? I know we had quite a few people that worked with refugees that had originally signed up.
It looks like there's a question about the state refugee health coordinator and whether or not they were involved in this endeavor. You know, we really, I think the reason we were successful is we did a lot of networking, and we thought a lot about who are advocates that really believe in this and want to see medication safety in all populations in Oregon. The refugee health coordinator was a wonderful advocate, shared data with us, linked us to other people who are working in the various communities. We didn't want, you know, the question about which languages, we didn't just go on data. We also met with people, leaders in the different language communities, just to make sure that we had it right. So yes, he was really helpful to us.
Great. Yeah, I was always really impressed when I looked at your list of organizations that were supporting the bill, and to read all the testimony, and then you know, even the committee chair just thanked the nurses for the wonderful job that they did. I was like, wow, that's really great to get a commendation from the chair. So.
And as Kate mentioned, a lot of the students had never even been to their state capital, much less testify in front of these important committees. So it was
a great experience.
It really was, yeah.
Mm-hmm.
And Kate, you did a really great job testifying in Nevada as well. So
Thank you. Thank you.
Very good speaker. Any other questions or comments? Okay, well, I guess that wraps it up then for today. I want to thank Kristen, Kate, and Ariana for joining us. For all the listeners, we've been recording this. We will be posting that up, and we'll be sending a follow-up email so you can rewatch it or share it with friends. And I just want to thank everyone for joining us. Have a great afternoon.
Thank you so much.
Thank you.